Welcome to your last lecture on cytology. Cytology is the study of cells. And remember that the prefix cyte means cell, and their structure, role, biochemistry, and communication and behavior. In this lecture, we're going to discuss methods used to collect samples of bodily tissues and fluids, the procedures that are used in examination of these samples, and the methods that we use to differentiate between inflammatory and cancerous samples. And we're also going to perform an impression smear and a fine needle aspirate. First, we like to make a distinction between cytology and histopathology. Cytology is the study of individual cells, whereas histopathology is the study of tissue. Cytology can be run off of fluid samples, samples collected from mucosal surfaces or secretions, and they're generally easy to collect. Histopathology or biopsies are ran off of tissue that is taken as a biopsy sample, and they're generally harder to collect, and the patient usually needs to be anesthetized or at least given local anesthetic. These tissue samples examine the cells and how they relate to their neighboring cells within the tissue. These are more complex tests that use more complex equipment and stains and fixative solutions like formaldehyde. So let's talk pros and cons of cytology and histology. Some of the pros of cytology is that it's less invasive. We can often get a sample through using a small needle or an impression smear. The results can be quicker because they can be done in-house. They may be sent out, and if they are sent out, they are less expensive than biopsy tests. And again, the samples are easily collected. Some cons are that if we don't get enough cells or the right cells, that we may be unable to see the entire tissue. We may have interference from severe inflammation, and often we can get inconclusive results. With biopsies, some of the pros are that we get a more accurate result. We have more tissue, we have more sample, we get answers on cellular makeup of the tissue, and these are also always sent out to pathologists for diagnosis. These tests are more expensive because they need more specialized equipment to cut the tissue and also to stain it, and they also need to be put in formaldehyde before being sent out. Also, you need a larger sample from the patient, and the patient is going to most likely be under anesthesia or in surgery because we need to be sampling a large piece of tissue. So there are more risks associated with biopsies. For example, if we do a liver biopsy while patient is anesthetized, there's a big possibility that they may hemorrhage out. There are a few different methods used to collect cytology samples, and depending on where and what we're collecting is going to determine what method we use. Sometimes the sample is swabbed, sometimes we do a skin scraping, sometimes we can do imprints or impressions, which is what you're looking at here on the right. We're just basically pressing the slide against whatever lesion or wound to try and get some cells on the slide. Fine needle aspirates or FNAs. Centesis, which is where we pull fluid, like from the abdomen, for example. Transtracheal or bronchial washes. And with tissue, we use biopsies like punch biopsies, for example. Swabs are used when an aspirate or imprint or scraping cannot be done. So examples of where we would need to use a swab are the ear canal, the nasal cavity, the vagina, or any fistulous tracts. When collecting a swab sample, sterile isotonic fluid like 0.9% saline should be used to moisten the swab. This helps to minimize cell damage during sample collection and smear preparation. For the collection of vaginal swabs, the animal needs to be restrained with in a standing position with the tail elevated. The vulva needs to be rinsed and cleaned, and then using a speculum that's lubricated or a plastic tube, it gets inserted just cranial to the urethral orifice in the vagina, and the cells that are collected are those that have exfoliated or shed from the vaginal wall, like epithelial cells and neutrophils, or red blood cells that are passing through the vagina during proestrus or estrus in the female. If collecting a sample from a moist lesion, the saline is not necessary, or if the ear is moistened, it's not necessary to add the saline. After sample collection, the swab is gently rolled along a flat surface of a clean glass microscope slide. The swab should not be rubbed across the slide surface because this causes excessive cell damage, so it's a gentle roll. Ear swab samples may contain excess amounts of wax, and this may interfere with the evaluation of the sample. So to minimize this effect, gentle heating of the slide or heat fixing may be necessary. Passing the slide briefly through a flame or gentle heat from a warm hair dryer may be used to dissolve the wax. And we also use a lighter. Excess heat must be avoided because it will destroy the cellular components of the sample. Aside from the gram staining procedure, this is the only circumstance under which cytology samples may require heat application. Our next technique is the imprint or impression smear, which is simply just holding the slide and pressing gently against the lesion. This can be done on external lesions, on living animals, or on tissues that were removed during surgery or necropsy. These are easy to collect, require minimal restraint. However, they do collect fewer cells than scrapings and have a greater amount of contamination from bacteria and other cells than a fine needle aspirate, for example. As a result, these imprints from lesions often reflect local secondary bacterial infections or inflammations, and they may hinder the accurate diagnosis of cancer. To collect imprints from tissues that we've taken from surgery or necropsy, the blood and tissue fluid should first be removed from the surface of the lesion being imprinted by blotting with a clean absorbent material, and excessive blood and tissue fluids inhibit tissue cells from adhering to the glass slide, thereby producing a poorly cellular preparation. In addition, excessive fluid inhibits cells from spreading and assuming the size and shape that they usually have on air-dried smears. If a delay occurs from the time of sample collection until the imprint is taken, a scalpel blade should be used to expose a fresh surface before blotting and sampling the surface. The middle of a clean glass microscope slide is then touched against the blotted surface of the tissue to be imprinted, or the exterior lesion, no matter what we're doing. And multiple imprints, again, should be made. Whenever we're doing cytology, you should get as many samples as you possibly can, or as many as the animal will allow you to do, because again, it is very possible to get inadequate amount of cells and inconclusive results. The next technique is the FNA, or fine needle aspiration. Your lab procedure book calls them fine needle biopsies, which I find confusing. But to be fair, when we do biopsies with needles, they're much bigger. So this is the most common technique for cytology, and they may be used to collect samples from masses, lymph nodes, nodular lesions, and even internal organs. For cutaneous lesions, they provide an advantage over other methods because they avoid superficial contamination from bacteria and cells. However, fewer cells are usually collected than with other methods, such as scrapings. Fine needle aspiration can be performed by either an aspiration or a non-aspiration method, which we'll talk about in the next couple slides. Preparation for fine needle biopsy is going to depend on where you're sampling from and how much you're going to need. So for example, if you're doing abdominal centesis, you're going to have to be much more sterile, or if you're going in a joint, you're going to have to do a sterile prep. Whereas if you're just sampling a small amount of cells from like a lipoma, for example, you can swab it or clean it with alcohol. And also there are some instances where you wouldn't want to clean the area because we're trying to diagnose something that we don't want to wash away. So these are very handy for lipomas, for example. And if you look on the right, on the top picture is fat cells. And if we poke a lipoma and we see on the slide that it's mostly fat cells, then that's a quick, easy diagnosis for a lump or bump. And then on the right bottom, you can see that these are cancerous cells taken from a cancerous lesion. One method of doing a fine needle cytology is without aspiration. This technique's easier to perform than aspiration because it doesn't involve directing the syringe and needle and pulling the plunger with the same hand. The mass to be sampled is held firmly to help with the penetration of the skin and mass and to help direct the needle. A 22 to 25 gauge needle is introduced into the mass. 22 is preferable. A lot of people believe that a needle smaller than 22 gauge may lyse cells. The needle is introduced into the mass, and a syringe with the plunger removed may be left attached to the needle to handle it better. And you can see this syringe on the bottom here doesn't have a plunger. We're just using it to direct the needle. The needle is moved rapidly back and forth through the mass 5 to 6 times along the same tract. The cells are collected by shearing and by capillary action. The needle is then removed from the mass and attached to a 10 ml syringe that has been pre-filled with air. And the air is used to expel the material onto a clean glass microscope slide by rapidly depressing the plunger. The expelled material should be smeared using one of the techniques that we're going to talk about later on in this lecture. And when we sample using aspiration, we use a 22 to 25 gauge needle again and 3 to 12 or 20 ml syringe. The softer the tissue that's going to be aspirated, the smaller needle and syringe need to be used. The use of a needle larger than 21 for aspiration is not usually an advantage even for firm tissues such as fibromas. When larger needles are used, tissue cores tend to be aspirated, thereby resulting in a poor yield of actual free cells that are suitable for cytology. In addition, larger needles tend to cause greater blood contamination. The size of the syringe that is used is influenced by the consistency of the tissue being aspirated. Softer tissues, such as lymph nodes, often may be aspirated successfully with a 3 ml syringe. Firm tissues, such as fibromas and squamous cell carcinomas, require a larger syringe to maintain adequate suction for the sufficient collection of the cells. Because the ideal size of the syringe is not known for many masses before we aspirate it, a 12 ml syringe is a useful size because it's somewhere in the middle. The mass to be aspirated is held firmly and to help with the penetration of the skin and mass to control the direction of the needle. The needle with the syringe attached is introduced into the center of the mass, and strong negative pressure is applied while withdrawing the plunger to approximately 3/4 of the volume of the syringe. Several areas of the mass should be sampled. Again, we want as many samples as possible, but aspiration of the sample into the barrel of the syringe and contamination of the sample by aspiration of the tissue that surrounds the mass must be avoided. To accomplish this, when the mass is large enough to allow the needle to be redirected and moved to several areas in the mass without danger of the needle actually leaving the mass, negative pressure is maintained during the redirection and movement of the needle. However, when the mass is not large enough for the needle to be redirected and moved without danger of leaving the mass, negative pressure is relieved during the redirection and movement of the needle. In this situation, negative pressure is applied only when the needle is static or not moving. High quality collections often do not have aspirate material visible in the syringe and sometimes not even in the hub of the needle. So you may have gotten a bunch of cells, but you may not necessarily be able to see it. To get the sample on the slide after an FNA, well, first when we're removing the needle from whatever we're sampling, we let go of that negative pressure before we pull out. So we're going to have to remove the needle so that we can pull back on the plunger to get some air in that syringe, and then we reattach it to the needle. And once we do that, we push that air and we push the sample right out of the needle onto the slide. And we do this several times until there's nothing left coming out of our syringe and needle. And then once we do that, we're going to prepare what is called a compression or squash smear. And this is done by using a top slide, a puller slide, similar to a blood smear. And instead, we just put it flat on the other slide and pull. There are several different ways to do this, and I'm going to discuss that in the next slide. So for our compression, smears, or squash preps, what we're going to do is expel that sample onto the slide first. And this has to be done in a specific way. Otherwise, the cells may be ruptured. But we expel the sample onto the middle of one slide, and then we place a second slide, the spreader slide, over the aspirate, horizontal and at a right angle to the first slide. As you can see in step B here, the spreader slide is then quickly and smoothly slid across the prep slide. So downward pressure should not be placed on the spreader slide because this may cause cell rupturing, making the sample unable to be interpreted. And there are several modifications of the compression prep that has less tendency to rupture cells. And one of them is to lay the second slide over the aspirate and rotate it to about 45 degrees, which you're looking at in C, and then lift it upward. Another technique that's mentioned in your book is a combination technique of the two. To obtain fluid samples, it is called centesis. So centesis refers to the introduction of a needle into any body cavity or organ for the purpose of removing fluid. The collection of fluid from the peritoneal cavity is called an abdominocentesis or paracentesis. And the thoracic cavity is called thoracocentesis. These are commonly performed in small animal practice, as well as cystocentesis, which you guys know by now is aspiration of urine from the bladder. Fluid samples for cytologic evaluation may also be collected from around the spinal column and from within joint space, and this is called arthrocentesis. And you can see in this picture on the right, there is joint fluid within the cavity, and on the bottom right, we have a dog getting an abdominocentesis, and they're pulling fluid from the abdomen. Fluid can also be pulled from the eye. General anesthesia is required for the collection of cerebrospinal fluid, or CSF, and also synovial fluid from the joints, and aqueous and vitreous humor from the eye. So all of those would require anesthesia, whereas usually we can perform an abdominocentesis and even thoracocentesis without the animal being anesthetized. Before the collection of peritoneal or pleural fluid also refers to fluid in the thoracos cavity or the thorax. Before we do either one of those, the site needs to be aseptically prepared, and all equipment and supplies should be gathered and ready. Preparing several smears from the fluid as soon as it's collected is helpful so that we have a plentiful supply of glass slides. Portion of the fluid should be collected in an EDTA tube. A 21 gauge needle is most commonly used and should be attached to a 60 ml syringe. For small animal patients, thoracocentesis is usually performed with the animal in a standing position and the needle inserted in the 7th or 8th intercostal space along the cranial aspect of the rib. Abdominocentesis may be performed in a standing position or with the patient in lateral recumbency. The needle is introduced to the ventral abdomen to the right of the midline, approximately 1 to 2 centimeters caudal to the umbilicus. The procedure is slightly different for exotic and farm animals. And Although thoracocentesis and abdominocentesis are pretty common in vet med, synovial joint fluid pulling is not as common, but it can be done in the stifle, the elbow, the carpus, and the tarsus. This is more of a large animal thing, joint fluid, and CSF taps are usually done by specialty hospitals, usually by a neurologist, and with the aid of a CAT scan or MRI machine. So why are these procedures performed? They're performed for two reasons, basically. For diagnostic reasons, as we mentioned, you would most likely pull or fill a purple top tube with some of this fluid, and sometimes a plain top tube as well, to send out for cytology. And because we want to know why this patient is accumulating that fluid and what's in it. And also for therapeutic reasons. As you can see on the right, this patient has a lot of pleural fluid, all that cloudiness in the chest, and that is called pleural effusion when there's fluid in the chest cavity, and ascites when it's fluid in the abdominal cavity. And when these patients have this amount of fluid, they have problems breathing. So removing the fluid is going to help them to have ease of breath, and from the abdomen as well, because it allows the diaphragm to expand. So we're doing this to make them comfortable and for diagnostic reasons. When there is a large amount of fluid, something that is helpful is a three-way stopcock. And that is what is here on the bottom right. And basically this allows you to, you change directions on here. So one direction when you're pulling the fluid off, and then you change the direction and the fluid can go into a bowl. So you don't have to keep changing your syringe. You can just change the direction of the stopcock, because sometimes you can fill up a huge salad bowl worth of fluid coming out of an animal, and it just makes life easier. So some of the things you'll need for centesis, remember that this requires aseptic preparation, so you would clean and scrub similar like you would before surgery prep. They can be in lateral or standing positions. You're going to need a needle, preferably a 20 to 22 gauge. Butterfly catheters work well because they can kind of move around a little bit better inside of the abdomen. A syringe, obviously, and the size is going to depend on how much fluid you expect to pull off of the patient. Again, a stopcock is helpful so that you can redirect that fluid to a bowl. Remember, the bigger the syringe, you're going to have more negative pressure, and it's going to be harder to pull back on the syringe. The three-way stopcock can help you to direct the fluid out into another source like a bowl so that you don't have to keep disconnecting the syringe. The direction of the stopcock, if you look at the above picture, the stopcock is facing towards the tubing. So right now it's open, meaning that if you pull, the fluid is going to come into the syringe. And if you turn it towards the other side of the tubing, then you would push the fluid out into an exterior source like a bowl. You should also have sterile gloves for these types of procedures, and not like this person in this picture. And you should have tubes ready for your sampling. So purple top tube, a red top tube ready to put that fluid in it, a bowl for bigger amounts of fluid. And remember, this might get messy, so wee-wee pads are great. Sometimes the aid of an ultrasound can help you find the right placement. And remember, these patients probably are going to have difficulty breathing, so they might need oxygen therapy as well during this procedure. Some complications that may occur during a centesis is inadequate fluid flow. If there's a lot of fluid in that abdomen, it's going to come out relatively easily. If there's a small amount, it may be more difficult. Also, sometimes the needle may be up against the body wall or an organ. And this is one reason why the butterfly needle is helpful, because you can hold on to it a lot easier and move it around a little bit. Also, the patient may move. They may be uncomfortable. Sedation may be needed for this. Unfortunately, most of these patients, again, are having trouble breathing, or they already have some kind of heart disease that's causing the fluid in the chest or abdomen. So sedation is usually contraindicated in these patients, I mean. So again, with a patient like that, you might consider standing restraint because it's a little bit easier to just keep them standing. And this is possible when you're doing an abdominal centesis. Whenever we pull out fluid from a patient, we want to record the volume. And this is much like our other samples. The color, the volume, everything about the sample can tell us something about the pathology and what's going on here. If it's red, we could have hemorrhaging. If it's cloudy, that could be from inflammation and a lot of white blood cells present. So we always want to record the turbidity and the color and the volume of the fluid that we pulled out of the patient. For obtaining respiratory samples from the trachea or bronchi or bronchioles, we have two different procedures that we use, and these samples are used to diagnose pulmonary disease in small and large animals. The bronchoalveolar lavage is a method that's used with a bronchoscope. So a scope is needed for this method, and that's what you're looking at on the right here. It's a picture of the inside of the respiratory tract by the scope in a horse, and this is the video on the next slide. And these samples are considered more diagnostic. There's less of a chance for them to get contaminated because we're collecting samples directly from the inside of the respiratory tract. A transtracheal wash allows more options because a transtracheal wash can be done 3 different ways. It can be done with a catheter passed through an endotracheal tube in an anesthetized animal, which is referred to as an orotracheal approach. It can be done through the nasal passages, which is referred to as nasotracheal, or through the skin and trachea, which is referred to as percutaneous approach. So there are more options with the transtracheal wash. However, there's more potential for contamination. As we mentioned, this procedure can be performed in 3 different ways. The most common is with the use of an endotracheal tube. The patient is sedated, and then the endotracheal tube is placed, and then we pass a small rubber catheter down through the ET tube, through which we infuse the respiratory tract with saline. The saline mixes with the respiratory tract cells and fluid, and then it is aspirated back up. So that's why it's called a transtracheal wash. And this is how we get our respiratory sample. Now again, this can also be done through the nasal passage, and that is a good way to get samples in the pharynx, and the catheter can also be passed through the skin directly into the trachea. And obviously if we're doing this, we're going to have to make a hole in the skin to go into the trachea, and this requires a very aseptic preparation. Also, any fluid that the patient coughs up afterwards can also be used as a sample. That is obtained in these procedures can be classified as transudate, modified transudate, and exudate. The main difference is the cellular contents and the total protein readings. The transudate's usually clear, colorless, with low cellularity or a low amount of cells, and the total protein is lower than 2.5. The modified transudate will be slightly turbid, usually white, moderate cellularity, and the total protein value on the refractometer is going to be between 2.5 to 5. The exudate is usually turbid. The color will depend on the cause. There could be possible blood contamination and high cellularity, and the total protein is higher than 3. So the main difference between the transudate and the exudate here is the cellularity. There's much more cellular content in the exudate. The main mechanisms from which effusion can occur, again, are transudation and exudation. And you can see on the right, we have an example of pleural effusion, and the transudate occurs due to increased hydrostatic pressure or low plasma oncotic pressure. And then the exudative occurred due to inflammation and increased capillary permeability. So that you can see through inflammation why we might have more cellular contents in the exudate. The transudation is due to altered hydrodynamic forces within the vessels serving or draining capillary beds or the interstitium, like lymphatics. Some causes of transudative pleural effusion are increased plasma hydrodynamic pressure. This is usually from increased venous pressure, like hypertension, but can be from increased blood delivery to capillary beds, arterial hypertension or dilation. although the latter is less common. Decreased lymphatic drainage or increases in tissue hydrostatic pressure, decreased plasma oncotic pressure, and hypoalbuminemia. Exudation, this is due to increased capillary permeability and is mediated by vasoactive mediators, usually as a consequence of inflammation. This may or may not be accompanied by chemotaxis of leukocytes in response to inflammatory cytokines. Generally, these fluid cytology samples are sent out to a lab, and as I mentioned before, you usually collect the fluid in a no additive tube and an EDTA tube. Sometimes for transudates, we centrifuge them down, and this would be done for 5 minutes at 1,000 to 1,500 RPMs, that's the speed. And afterwards, the supernatant is separated from the sediment and analyzed for total protein. The sediment is resuspended in a few drops of supernatant by gently flicking the side of the tube, and then a drop of that resuspended sediment is placed on a slide, and a smear is made using the same technique that we use to make a blood smear. When possible, several smears should be made using each technique. The addition of plasma may help cells to adhere to the microscope slide, and after air drying, the slide may be stained with a Romanowski type stain. Multiple slides, again, are often made when we're sending out to a lab. They do like that you send one stained and one unstained slide, and some may prefer just the fluid without the slides. It really depends on the lab that you're sending it to or who's doing the sample in-house. Another technique that is useful for more viscous or thicker fluids is the starfish technique. And this basically is placing some of the fluid onto a slide and pulling out in different directions to make a starfish shape, because this helps the cells to spread out more than they would due to the thickness of the sample. The cells won't usually spread on the slide without using this technique. So this technique is preferred for more viscous type fluid. Very common uses of cytology are vaginal cytology and the diagnosis of neoplastic or cancerous lesions or cells. So we're going to talk about what some of those things look like specifically. Common use of vaginal cytology is to determine the stage of estrus that the patient is in. Depending on the stage of estrus that they are experiencing at the moment, the cells that we sample are going to look different. In the pro-estrus stage of estrus, which is before estrus, we're going to see cornification of vaginal epithelium. Cornification is a term that means a programmed cell death that changes the cells and helps to form many things in the body, including hair and nails. And if you look over here, you should see the big squamous epithelial cells. These are going to look similar to what they do when you saw them in the urinalysis module, except these are stained, and they're going to have small nuclei. The cell edges are going to be thin and can fold over. There's going to be a lot of red blood cells in the sample, and there may be low to moderate neutrophils in the sample. During the estrus stage, the epithelial cells of the vaginal epithelium are going to be fully keratinized or undergone cornification, which are basically the same terms, but at this point, they will be converted into another type of cell, and they will look different. They will have no nuclei, they will be irregular in shape, and you're not going to see any red blood cells or neutrophils. After estrus is metaestrus, and the cells that were keratinized will be shed, and the vaginal epithelium will start to return to normal, and the epithelial cells that we see will be round with round nucleus, and they'll be plump and cohesive or sticky and sticking to each other. There will be abundant neutrophils, but the red blood cells will be absent. Lastly, we have diestrus, where we're going to see a decline in the superficial cells. It will look similar to metastrus, but we'll also see strands of mucus. And you can see in this picture on the right, all of those stringy looking things are mucus that the cells are caught up in. Suspect cancer, the cytology is going to look a little bit different. And most often, these cytologies are going to be read by either experienced veterinarians or pathologists. But we can see things such as lymphoma, carcinoma, or sarcomas. And if we see signs of cancer, usually this is the type of mass that will likely spread or is locally invasive. So if something is malignant neoplasia, it is cancer. And usually these cells will have at least 3 of what we call abnormal configurations. So some of those abnormal configurations include the presence of pleomorphism, which is the same cell that is having unusual variation in cell size and shape. So it's the same cell type, but the cells of the same type look different, either in size or in shape. Also, if there's any type of variation or high nuclear to cytoplasmic ratio, meaning that the nucleus is rather large and there's less cytoplasm than there normally would be in that type of cell. Some other changes in the nucleus that may indicate a cancerous process include anisokaryosis, which is a variation in the nuclear size cell to cell. So if the nucleus is small in some cells and large in others, if we're seeing mitotic figures within the cells, signs of mitosis, if we're seeing multiple nuclei in one cell, or if we see any nucleoli changes, like variable size, shape, or number. So if you're seeing any of these changes, at least 3 of them, this is most likely a mass that has been aspirated that is cancerous. However, inflammation can interfere, whereas we're going to see inflammatory cells. So if there's any doubt in a sample that you are looking at under the microscope, it should be sent out to a pathologist. That concludes our lecture and our class. So if you guys have any questions, please reach out and let me know before the final exam.